Hello everyone, welcome back to the EMG nerve conduction study course. Hope you had a great holidays and a very happy new year. My name is Dr. Saurabh Singhal. Accompanying with me is Dr. Rahul Khanna. We both are fellows in clinical neurophysiology at University of Texas Houston. In our prior videos, we talked about some of the fundamentals pertaining to the EMG and nerve conduction studies. In this video, we'll be talking about peripheral neuropathy. This is one of the very important topics because it's one of the commonest clinical cases that we see in our outpatient practice. So, Dr. Rahul Khanna, can you please tell us what would be the main highlights of our study video today?
Sure, Dr. Singhal. Thank you for introducing me. So this slide shows us what we will be going over today, and we will briefly go over the classification and then differentiate how we can differentiate between axonal and demyelinating neuropathies, and go over few examples of peripheral neuropathy like diabetes, GBS, and also an example of hereditary neuropathy like Charcot-Marie tooth. Dr. Singhal, can you tell us how can we classify peripheral neuropathy?
Sure, Dr. Khanna, thank you. Now, peripheral neuropathy can be classified on a different types of basis, but based on the underlying nerve pathology, we can mainly classify into axonal and demyelinating neuropathies. And in our subsequent slide, we'll be talking more about these with examples and cases. And then there are certain mixed type of neuropathies where you see both axonal and demyelinating pathologies. So, Dr. Khanna, what do we mean by axonal and demyelinating neuropathies and how do we differentiate this? Can you please tell us?
Sure. Yeah, I think this was the great way to classify neuropathy, especially for this lecture, as we are going to concentrate on EMGs. And let's look at what is axonal and demyelinating neuropathy on nerve conduction parameters. As we know, on axonal neuropathy, we will have normal latency, reduced amplitude as amplitude decreases in axonal neuropathies, and conduction velocities and late responses are usually normal, whereas in demyelinating neuropathy, latency and conduction velocity are abnormal. Latency will be prolonged and conduction velocity will be reduced, as well as late responses will be prolonged as well. This is mainly because of loss of myelin, which helps in the increasing the speed of the conduction, and thereby, if in demyelinating disorder, causing velocity to reduce. Also, a thing to notice is that happen in demyelinating neuropathy with some temporal dispersion. Only in acquired demyelinating neuropathy, but not in the hereditary ones. We can, I think we need to look into more detail of what a conduction block and and temporal dispersion is. Dr. Singhal, can you explain a little bit more to our viewers?
Absolutely. Thank you so much for teaching us about the differences. So, like Dr. Khanna mentioned, it's very important to differentiate or be able to differentiate the neuropathy into axonal versus demyelinating based on the pathologies. Now, let's look at this chart over here. Um, Here we have four charts A, B, C, D. Looking at the A, which is a normal case, what we see is here is we have two waves which have similar amplitude or the heights, and their latencies are within normal limits. The top wave represents the distal stimulation site, and the proximal site is recorded by the bottom wave, and this represents a normal variant. Now, when you compare the normal variant with chart B, we can easily see that there is a significant loss of amplitude or the height of both the waves, and I repeat, both the waves. This is typically something that we see in axonal neuropathies. Coming to chart C, we can see that the amplitudes are preserved where you see the normal heights of the waves compared to the chart A. However, we can see the waves are starting pretty much late compared to chart A, or technical terms we say that they have prolonged latencies with preserved amplitudes. This, as we know, is typically something that we see in demyelinating neuropathies. Also, we can see the conduction velocities are reduced here, which was relatively preserved in the axonal neuropathies and the normal variants. Now, when we see chart D, here we are seeing that compared to the top wave, the bottom wave, which is recorded at the proximal site, you have a reduced amplitude and increased duration. Not only both the waves have prolonged distal latencies compared to the chart A, but the bottom wave, like I said, has reduced amplitude and prolonged duration, which is something what we were referring to as conduction block and temporal dispersion, which are characteristics of acquired demyelinating neuropathy. So what is conduction block? Conduction block is reduce or reduction of Cmap amplitude and or area of more than 20% elicited by proximal versus distal motor stimulation, and temporal dispersion is increase in Cmap duration of more than 15% elicited by proximal versus distal motor nerve stimulation. And whenever we see these two, these should make us think about the possibility of acquired demyelinating neuropathies. So let's talk more about this. And so, Dr. Khanna, tell us more about what else we need to know about axonal versus demyelinating neuropathy, or some of the important points that we need to recap here.
Sure, Dr. Singhal. Let's summarize what we already saw. So in axonal neuropathy, we know that amplitude decrease and conduction velocities are normal, or it can be slightly decreased also, but they are never below 75% of lower limit of normal. And distal latencies are normal in axonal neuropathies, but can be slightly prolonged, but never more than 130% of upper limit of normal. This is because when axons lose the nerve fibers, uh, their amplitudes decrease, but even if they lose the uh, fastest fibers, even the slow conducting fibers, their inherent conduction velocity is never below 75% of lower limit of normal. Uh, the conduction velocities can go below that only in demyelinating neuropathy when they lose the myelin on the nerve fibers. The conduction velocities fall in that range. So when we see demyelinating neuropathy, it is associated with marked slowing of conduction velocity, which is slower than 75% of lower limit of normal, which is also called the demyelinating range of conduction velocity. And distal latency would be very prolonged. It would be longer than 130% of uh, upper limit of normal, again in the demyelinating range. Decrease in amplitude can happen in demyelinating neuropathy, but only if there is a secondary axonal loss, or if there is conduction block present, as Dr. Singhal explained earlier. The conduction block can happen in demyelinating neuropathy because the nerves are conducting slowly, and the difference between different nerve fibers can result in temporal dispersion and phase cancellation, leading to this loss of amplitude. So these criteria should be kept in mind while analyzing if the lesion is primarily axonal or demyelinating. We can this is the summary of what axonal and how we can differentiate between these two neuropathies. Dr. Singhal, can you give us some examples of demyelinating and axonal neuropathies, please?
Sure. So, like we discussed, neuropathy are classified into demyelinating, axonal, and mixed. The demyelinating can be further classified into hereditary neuropathies, such as Charcot-Marie tooth disease, or acquired neuropathies, or acquired demyelinating neuropathies, such as AIDP, CIDP, MMN or multifocal motor neuropathy, anti-MOG neuropathies, etc. And like we discussed prior, acquired demyelinating neuropathies, we would often see conduction blocks and temporal dispersions, which we typically do not see in hereditary demyelinating neuropathies. And coming to the axonal neuropathies, so axonal neuropathies are there are a lot of variety of axonal neuropathies which we commonly see in clinical practice, including diabetes, which is the most common cause of acquired neuropathies, toxic nutritional amyloidosis, mononeuritis multiplex, etc. And mixed neuropathy, like we say, where we can have characteristic findings of both axonal and demyelinating neuropathies. And diabetic neuropathy is one such example where we can have both these features. So, Dr. Rahul Khanna, what else do you think we should know about diabetic neuropathy, especially the fact that it is so common and we see this quite so often in the clinical practice?
Sure. So, diabetic neuropathy, as we know, that is predominantly axonal neuropathy, but it can be mixed also, as Dr. Singhal very clearly pointed out. Diabetic neuropathy does affect long nerves first, so it presents as a length-dependent symmetric neuropathy. It can have various different forms. And examples, but this is the most common form of diabetic neuropathy. Uh, as we know, the nerve conduction changes would show predominantly axonal pattern, which will be reduced amplitude with preserved latency and in length dependent patterns. And the length dependent pattern is very important key to diagnose these neuropathies. For length dependent pattern, in the sensory studies, we will see involvement of sural first and then ulnar, then median, and then radial nerves. Whereas in motor neuropathies, peroneal nerve will be involved first, tibial after peroneal, and then ulnar, and then median. And this pattern is basically based on the length of these nerve. The length of sural is much longer than the ulnar and median compared to and similarly, length of peroneal is longer than tibial, ulnar, and median nerves. And EMG changes are also noted in a length-dependent pattern. We will see neurogenic motor unit action potentials in the distal muscles compared to the proximal muscles, which will have long duration polyphasic units and long amplitude also depending on the chronicity of the disease process. So, Dr. Singhal, can you give an example of diabetic neuropathy?
Certainly. So we think that it is really important to go through an example set of how an axonal neuropathy would look like. So we have given here a reference case example of a diabetic neuropathy. So we can see here what Dr. Rahul Khanna was mentioning about the length dependent pattern. So say for example here the sural sensory nerve is no response. However, for the ulnar and median sensory nerves have reduced amplitudes with preserved latencies and conduction velocities, which is typically a characteristic feature of axonal neuropathies in a length dependent pattern, further signifying the diabetic neuropathy. And similarly, in the motor studies, we can see that first, when we focus on the peroneal nerve, on the motor nerves, we can see that it has severely reduced amplitudes with relatively preserved latencies. However, if we go to the tibial motor nerves and then we go to the ulnar motor nerve and then to the we go to the tibial motor nerve, then we go to the median nerve and the ulnar nerve, we see that there is a length dependent pattern where we are seeing normal amplitudes in the ulnar and median motor nerves, uh, but reduced amplitudes in the tibial nerves, but severely reduced in the peroneal nerves. Similarly, if we look into the EMG or needle EMG study chart of this example, we can find a similar length dependent pattern where both on the sides of spontaneous activities and voluntary motor unit action potentials, we can see a length dependent pattern where we are seeing increased insertional activities with abnormal spontaneous activities more on a distal muscle such as right extensor hallucis longus in comparison to the proximal muscles such as right tibial anterior and right medial gastrocnemius where they are reducing, and finally coming to the right vastus lateralis and gluteus medius where we are seeing no abnormal spontaneous activities. And same thing with the motor unit action potentials or the MOAPs. We are seeing more chronic motor unit potentials in terms of prolonged amplitudes, prolonged durations, and presence of polyphasia more in the distal muscles compared to the proximal muscles. So this pattern of length dependent involvement is very important to identify in cases such as diabetic neuropathies. Now let's talk about demyelinating neuropathy. So Dr. Rahul Khanna, can you similarly give us an example and talk about demyelinating neuropathies? How do they present and how can we identify them on the clinical EMG charts? Thank you.
Thank you, Dr. Singhal. Sure, let's talk about GBS and CIDP, which is a common demyelinating neuropathy that we know of. And GBS and CIDP are predominantly demyelinating neuropathies, and we use EFNS criteria to diagnose CIDP. We'll briefly touch that, and in the nerve conduction chart, we will see that demyelinating neuropathy like GBS and CIDP will have increased latencies, decreased conduction velocities, and a relatively preserved amplitude. As we mentioned earlier, that amplitude can be decreased if there is presence of conduction blocks and temporal dispersion. And in GBS and CIDP, we can see these presence of conduction blocks and temporal dispersion, which basically indicates that this demyelinating neuropathy is acquired in etiology. So this is a quick uh, brief of EFNS criteria of CIDP. I am not gonna go into detail of this criteria, and can certainly look into the EFNS criteria and ask questions in our detailed session um, in the room. We'll go over an example of CIDP case. We can see in this example there we can see conduction blocks in various nerves as pointed with these pointers. The median motor is showing amplitude from 6.4 to 1.2, which is definitely more than 50% of drop, and also 4.6 to 2.2 in ulnar motor, and in tibial it's going from 4.2 to zero point 0.5, and peroneal it is going from 3.1 to 1.0. So we can see conduction blocks in almost all the nerves. Also, if we look at the latency, they are prolonged and in the demyelinating range, and the conduction velocities are also reduced in the demyelinating range. So even if the amplitudes are low, we see that this is a demyelinating neuropathy because the latency and conduction velocities are in demyelinating range, and the reduction in amplitude can be definitely attributed to the conduction blocks that can be seen in the detailed waveforms, and most probably we would have seen the temporal dispersions also, which we cannot assess in this chart because the duration of the nerve is not given. um, so the presence of these conduction blocks definitely tells us that this is an acquired etiology of demyelinating neuropathy, and depending on the clinical scenario we can assess the patient for if the patient meets the criteria of GBS or CIDP or not. Definitely the GBS and CIDP is not an EMG diagnosis but a clinical diagnosis. So Dr. Singhal will go to the next example. Can you give an example of hereditary demyelinating neuropathy?
Yes, certainly. So, one of the examples of the hereditary demyelinating neuropathy is Charcot-Marie tooth disease. It's an inherited demyelinating neuropathy, except few axonal forms such as CMT2. Here we see uniform demyelination. So what this means is that compared to acquired demyelinating neuropathy, where we have patchy demyelination and patchy reduction in velocities, here we would expect a uniform reduction in velocities, indicating a uniform demyelination. And the nerve conduction changes, since it's a demyelinating neuropathy, would show increased latency, decreased conduction velocity with relatively preserved amplitudes. However, as we discussed earlier, since it's a hereditary demyelinating neuropathy, it would not have conduction blocks and temporal dispersion that we typically see in the acquired forms of demyelinating neuropathy, such as the case of CIDP that was beautifully described by Dr. Khanna before. So let's move on to this case example of how a chart of nerve conduction study would look typically for an inherited form of demyelinating neuropathy. So here we can see that there are prolonged latencies and reduced conduction velocities. However, compared to the so first of all, the prolonged latencies and reduced conduction velocities with relatively preserved amplitudes makes us think this as a demyelinating form of neuropathies. Further, if we see, we are not seeing any conduction block or reduction in amplitudes by more than 20% in each of the motor nerves here, uh, which tells us that this is not an acquired form of demyelinating neuropathy, rather, it's an inherited form of demyelinating neuropathies. So, these were the uh, typical examples that we used to elaborate how the different forms of neuropathies based on the pathology would look like in chart. Now, again, in clinical practice, we often see mixed patterns such as mixed pattern of diabetic neuropathy involving both axonal and demyelinating neuropathies, but we try to focus on the chief highlights that we can use to characterize the neuropathies into axonal and demyelinating forms, and further classify the demyelinating into acquired forms such as CIDP and inherited forms such as CMT. So, Dr. Khanna, what do you think would be the main takeaway home points from our study video today?
Thank you, Dr. Singhal. So, uh, let's see about some take home points. If you could just memorize all of the neurology, that would be great. I was just kidding. So yeah, take home points. Definitely, we discussed briefly on axonal and demyelinating neuropathy. What are the characteristic features on the nerve conduction studies, and how we went over this some of the examples of different neuropathies. So uh, remember about the land dependent pattern, remember about the conduction blocks, and demyelinating range of neuropathy. That would be, I think, main take home points from this slides. If you have any questions, we will be there in the session scheduled to discuss further cases, and all the questions would be welcome.
Well, that was a very great preview, I believe, for the topic today. Thank you so much for listening to our talk and hope you have a great, wonderful day. We'll see you back in the classroom soon. Thank